Great. Hi, everyone. Welcome. Thank you all for coming. My name is Lauren. I am the Education and Wellbeing representative of the MSC. And I have my wonderful colleagues, Jen and Elise, on with me who will introduce themselves in the second half. But we are very, very, very excited to have you guys, and we're looking forward to a great event today. We have so many amazing residents and attendings here to share all of their knowledge with you. So I will let them get started in introducing themselves real quick. Just the plan for today, they'll introduce themselves. We have some questions that y'all submitted before the event that we'll have them go over, and then we'll have time for open Q&A at the end. So you can do this one of two ways. If you just want to chat your question in, you can put it in the comments box whenever it comes up, and then we'll get to it during that time. Or if you want to just save your question and then you can, raise your hand on the Zoom function and introduce yourself and ask in person. So whichever you prefer works for us. But Dr. Singh, I'll have you introduce yourself first, and then we can just kind of popcorn and go from there.
Hi, everyone. Good evening. Sarang Singh. I'm a PGY4 resident at the Kessler Institute of Rehab and Rutgers PM&R program. I'm also on the RFC through the AAP, where I serve as the medical student affairs rep. So you guys have probably seen me on a couple of these seminars before. Reason why I went into PM&R was part of our introductions. And I think I love answering that question. PM&R to me was something I found late in medical school, but it really blended all the things that I liked about medicine the most. Primarily, that's the opportunity to get to know my patients on a personal level, to feel like I get to know them longitudinally, their family members, themselves, the communities that they live in, and building relationships that way, while also getting to do the fun hands-on things that I like about medicine, which is procedures, physical exam, and diagnostic procedures and so forth. So that was what really drew me to PM&R.
Thank you. Dr. Jones?
Hi, everyone. Good to see you all tonight. My name is Eric Jones. I'm a PGY3 at Mount Sinai in New York City. I'm also on the AAP RFC with Sarang, Dr. Singh. I serve as the vice chair, and that's been a great opportunity to get more involved with the AAP. As far as why I went into PM&R, I think what initially drew me in is kind of similar to Dr. Singh. I really wanted to work with patients kind of all sort of function and abilities, and I think PM&R really offers that. You get to meet people sometimes in their lowest state, and when they have a kind of new injury or new disability that they have to kind of learn how to live in their new body. And I think myself, being sort of a naturally positive person, I really wanted to bring that person hope, and I think the PM&R has certainly allowed for that. And I think secondly, what kind of was the hook for me in PM&R was really getting involved with the community, AAP, things like that. Still some of my really good friends are actually PM&R people that I've met along the way. Had a friend actually stay with me here in New York City when he moved into residency that I met through the AAP. So definitely is a great community, and one that you guys will find really enjoyable.
Great. Thank you. Dr. Ortiz?
Hi, everyone. I'm Pablo. I'm a PGY3 at Rutgers Kessler. Sarang is my chief, and he just matched to his paint program, which was really cool. So I'll let him talk about that more. But the reason why I went into PM&R was essentially for a lot of reasons. Mainly, there were two personal reasons. My dad was a very hard worker. He was a migrant worker working at factories, and so he dealt with a lot of pain. And I wanted to figure out a way to help him out. And so looking through the specialties that I was thinking of going into, PM&R was that good specialty that talked about finding function before trying any surgeries or anything. And I really love anatomy. That was one of the other reasons why. So it combines a lot of that stuff. And in addition, it brings in a lot of the representation that needs to occur. So I am involved in the representation and rehab program, which kind of talks about minorities in rehabilitation. So I like the community, I like the attendings, I like the stuff that we learn, and it's just a good combination of everything. So you guys are in for a ride if you decide to do PM&R. It's a great one, and I hope you enjoy it.
Great. Thank you. Dr. Perez?
Hi everyone, I'm Eliza. I am a PGY2 at Mount Sinai. So Eric is one of my seniors. One of the reasons I went into well, there's a lot, but PM&R was very personal for me. I had a sports injury in high school. My grandfather had many strokes. He was left a quadriplegic. So I saw the life he had, and he actually dealt with a lot of PM&R doctors. And then I had a friend who had a spinal cord injury. So among that, I I like found PM&R. I like the longevity of care. I love the MSK system. I like that it's a very collaborative field. You work with PTs, OTs, social work, and then also it's a good lifestyle after residency. So no one has touched upon that, but it is something to keep in mind.
Great, thank you. Dr. Fedorovsky?
Hey everyone, I'm Mike. It's good to be here. I'm an incoming, so next July I'll be a PGY2 at Nassau University Medical Center in New York. One of the more important reasons why I went to PM&R is the care is very patient driven. So the patient's goals, the patient's lifestyle is really what drives the treatment plan, and what changes are made along the way is based on the patient's progress or setbacks. So we're really focusing on the patient, and there's no one size fits all model in medicine. In PM&R, this is like 1,000-fold true. So the patient, the specific patient is what drives the care. So I thought that was really cool. And as a DO as well, I love using my hands and treating the patients. So I love getting in there, using injections, doing different kinds of treatment, Botox, ultrasound, and helping my patients. So yeah.
Amazing. So as you can tell, we have an incredible panelist of residents here. We're also lucky enough to be joined by two attendings. Dr. Russo, I'll have you introduce yourself.
Hi guys, I'm Dr. Russo. I'm a attending physiatrist at Kessler. I serve as the Associate Program Director for the Brain Injury Fellowship, and just recently took over the role of Clinical Chief for Brain Injury Services at the Saddlebrook campus. So I am a neuro nerd. Like I love the brain and all things neuro. But I felt limited as far as what neurology sort of as a field could do, and really fell in love with the opportunities that particularly brain injury medicine, which is my subspecialty, offered me for the recovery of patient. Beyond that, the field itself, I agree with what everyone said. It's focused on function and more the patient in their context, I think is particularly special. We really do understand the patient in terms of their entire community and as a whole person. And it's really very special to be focused on care that is so patient-centered. And we get to wake people up from disorders of consciousness, which is also really awesome. So that is it for me.
All right, thank you. And last but not least, Dr. Brombat.
Yes, my name is Drupal Brumbat. I am an SCI attending at the University of Louisville, VA. I am the APD of the SCI fellowship that we have here. And in terms of what got me into PM&R, to save time, I'll say ditto to everything everyone else has said. But to put simply, in terms of SCI, I really enjoyed that I get to be kind of a cheerleader, mentor, coach for these individuals as they've sustained a terrible injury, and kind of work them to living a fulfilling life, hopefully. And so that's what got me into PM&R.
Great, thank you. And we have one last resident to introduce herself, Dr. Scher.
Hi, Lauren. Thank you. Hi, everyone. My name is Jess. I'm a fourth-year resident at UW in Seattle. I'm applying to sports fellowship right now. I'm originally from New Jersey, and I did my training at Rutgers University. Thank you for having me.
Great, thank you all. So I'm going to get into our pre-submitted questions. The first question was, this is a panel for M1s, M2s, maybe some M3s are here. A lot of people find PM&R a bit late in medical school. So what advice do you have for medical students who recently stumbled upon the field and are interested in exploring it more? Also, you all can just unmute and start talking.
I guess I can take a stab at this one. I think something that I find sort of appreciative in hearing medical students and their experience in PM&R is really that they understand like the well-roundedness of PM&R, because we do treat so many different types of patients, and speaking personally from my experience in medical school, actually some unique experiences I had that I kind of stumbled upon was after my M1 year in the summer between M1 and M2, I volunteered at like a muscular dystrophy summer camp. And all the medical staff there were actually PM&R doctors. So I got to kind of explore like the neuromuscular side of PM&R. And it was really cool. You know, at that point, I thought PM&R was more like sports medicine and that kind of thing. And so seeing a whole new side of PM&R is really interesting. And then later, I kind of got more involved with movement disorders and actually even like Parkinson's and how PM&R and rehab can have such a big part in Parkinson's. And so I think just as a medical student, really exploring all those different avenues of PM&R, even some of these more niche areas, really goes a long way and shows that you kind of understand the field from a wide spectrum.
Yeah, I agree with Eric. I think the biggest way to find out if you want to do PM&R is do rotations and do as many as you can in like different specialties like pain, SCI, spine, TBI, and movement disorders if you can. But I think the best way is to really just do rotations and see if you like it.
I'd also like to, echo some thoughts. I came from a medical school that didn't have a in-house PM&R program, and some of us find out about PM&R, but we don't have sort of the infrastructure to explore it so easily. So I would recommend, if you do think that it's something that interests you, to go aggressive and email as many people as you can. It's public information. These programs have their program coordinators and their emails available. And I think it's smart to reach out, especially to programs in the region. For me specifically, I didn't have a program at my school, but I reached out to a program an hour away, and they were very receptive because it is a small community. They kind of understand that it's a little bit of a field that's a little more niche and not as widespread exposed in some schools. And that program really allowed me to do a lot. I was able to, go there, just, experience the facility and tour the facility for one day. And that really helped me understand more of what I was facing and if it would be a good fit for me.
To add on to what Sarang is saying, one other thing that I would talk to in terms of individuals that may not have a PM&R residency associated with their school, a great thing is we're in the 21st century, right? And so there's Instagram and Facebook and all these things, and you can see, parts of the day in the life of a resident at, this program. And so you can really get exposure to the field by just doing your research online. And then the other big thing is the kind of platforms that we're on currently, AAP, there's other organizations in PM&R as well that do great outreach and great educational series, so you can get a good understanding of the breadth of PM&R and get exposure that way.
Yeah, 100%. I agree with Dr. Brombat. I would say engagement with the national societies is really, really helpful. There's so much information, and we're actively, we have goal. I'm on the education committee for the AP, and we have goals. We have goals that are around getting this information out to you guys and getting it out broadly so that you not only see whatever small snippet you've seen, but you really get a good sense of what the entire field is.
Oops, Dr. Russo, you muted.
Sorry.
Yeah.
I would say engagement with the national committees, national groups for sure. Very helpful for getting more information about the field.
I would also say that reaching out to private practices of physiatrists or PM&R attendings is key. When I was applying to medical school, I knew that I wanted to go into PM&R and I wanted to get some volunteering opportunities. At that time, it was pretty rare to find like a fixed program, but so I reached out to attendings, and I just shadowed like for a day at the ambulatory prosthetics department. And so just kind of seeing on Google, using online to find people within your area, I think it's worth going in person, giving them an email or calling them to those private practices to see if they could have you at least for a day to see what PM&R is all about. It's really helpful.
This is great. And all of these responses answer our second question, which was about staying connected to the field of PM&R. So maybe asking a more rhetorical question for the group, but if a medical student were to want to get involved with the AAP, or other national groups, how did you guys get involved in those groups as medical students, and how would you recommend that students kind of reach out and start this online networking?
I'm gonna, I guess, age myself, but and say that I didn't do that early enough, and that's just because I wasn't as aware of it and didn't attend things like this. I don't have good advice in that regard. But I think just going to these type of conferences, if you have the ability to, or being able to reach out to these different residency programs and getting insights from there, I think is a good starting point if you don't know how to get involved, because your residents at these programs will know.
I will say after actually, Dr. Bromback, you said it earlier, which was that we're in the digital age. So you're able to follow these societies on Instagram. It's kind of low bar to do things like that. And from there, they'll post different events that are happening, things like that, that help. So I do think the social media makes it even more accessible. And it's pretty low bar to just click follow, so I think that can be helpful.
Yeah, I can say, I guess I can break it down into 3 different things that I'm thinking about. One, I mean, I know we keep talking about the AAP, but it really is a great organization to get involved with. The Medical Student Council itself is actually growing every single year. I just spoke with one of their members, and they have almost like 30 members, including subcommittee members at this point. So it is really growing every year, and they're always looking for new members. Secondly, with AAP, they have a mentorship program for medical students. I know I certainly utilized that as a med student, and it was really helpful to connect with a resident who helped me with my CV. We actually did like virtual research together. So we like put out some surveys, and we published 2 research studies just completely virtually. So that was really great for my, medical school application for residency. And then thirdly, I would just say Twitter. I know we've talked about Instagram a little bit, but also just kind of staying active, engaged on Twitter, kind of making a name and brand for yourself is always helpful. And people within the PM&R community are certainly welcoming and happy to engage.
Great, thank you guys. So our next question is asking, what about like jobs after residency? What do the jobs look like? And I know we touched on work-life balance, but anything you guys want to expand upon with that as well?
Well, I will say that I think for a long time our field was described as like a lifestyle field, and I would caution if that is at all like, oh, I'm really looking for like a lifestyle field. So medicine is hard no matter how you cut it, and there are draws on our time that are medicine's hard, period. So don't ever tell anybody you're interviewing with that you're going for a lifestyle field, because it's not. I'm an inpatient, and I do inpatient and outpatient. So, but I love it. So because I'm a BI attending, a lot of us choose to do inpatient, where we really get to see the kind of early steps as people recover. But inpatient services are busy, they're hard, they're long, and a lot of your training is going to be spent in an inpatient setting. Even if you decide you're MSK and you're going to be outpatient and all sports and spine, a lot of what you're going to do, particularly in those early years, the PGY2 year, is heavy. It's heavy rotations through an inpatient service. So I think being prepared with a mindset, knowing that like you're in medicine, medicine is challenging, is helpful. Again, even in the outpatient, there's all kinds of, it can be, anyway. So I just don't be surprised. It's still medicine. Let's put it that way. Okay, I'm done.
I think that's a great point to reiterate. One thing I will say, this question is almost so broad, and I would say that is a great strength of PM&R. You could be an inpatient attending. You could be a dual inpatient and outpatient attending, like Dr. Russo. You could be completely outpatient. You could be working at skilled nursing facilities. You could be doing consults at an acute care hospital and not being a primary member of being primary team, so you're not getting the calls overnight, but you're providing very helpful insights into these individuals that have had acute traumatic brain injury, traumatic spinal cord injury, all the various injuries. And so in terms of jobs, it's one of the, I think, biggest strengths of PM&R. You really could create a variety of practice structures that you may enjoy.
Agreed. I have one attending I worked with who spends half his year running marathons all over the world and then half his year doing locum tenens, and that's what works for him. And he was in academia before that, and he's done what he wanted to do, and now he lives a life. So not to, again, I didn't mean to poo-poo the lifestyle, but I'm just saying yes, I agree with Dr. Bromwell. There's a million ways you can practice and you can always find what works best for you. But all in all, medicine is hard. So.
And then residents who are pursuing different fellowships, if you want to touch on, some of the different paths that you guys have taken, maybe in residency, or things that you're looking to do after residency as well.
Yeah, so I'm pursuing a fellowship in pain management or pain medicine, more on the interventional spine side of pain medicine, and that is it's sort of like, it's always been a common sort of subspecialty from PM&R, mixed PM&R, anesthesia, and some other fields. Sort of increasingly so in recent years, we've seen higher numbers of PM&R residents applying towards sports and pain medicine. I think in terms of your question, for me, it sort of tailoring my residency experience to get as much exposure into that field as possible was key. So expressing interest prior to starting at my residency to my chiefs and to my administration so that they could help me generate a rotation schedule that allowed me to get good enough exposure early on to know if this is something that I actually enjoyed doing, because there's a lot of facets to that field that you need to understand, and the nuances of what that entails. So building your schedule, building your exposure to attendings and rotation sites, and then a lot of it too is sort of taking all the advice that we've given already during this webinar and then adding it to that subspecialty. So I also went to a lot of pain medicine conferences. I also did a lot of research in pain medicine, not just physiatry. So, if it's something that early on that you're interested in, you sort of attach it as like a two-pronged approach to like try to go after that as well alongside your physiatry training. But that's just me. I was very targeted with my approach. I knew I always wanted to do something in either sports or pain. But I think having an open mind is also really advantageous too, because at the end of the day, you're going to have to know a little bit of everything if you're going to have to be good at anything. So, yeah.
The pain match is also earlier than all the other matches, so it happens really, really early. So they really do have to, if that's a course that you're looking for, you really do have to be lightning focused as you come in, just because you have a lot to get done in a short period of time in order to be a competitive applicant. So it's the only one that's very, very early of the fellowships.
I will say this, since there may be a lot of M1s, M2s, and things like there. Dr. Singh has, if it's okay to say where you've matched, he's matched at a very competitive program. And so I just say this as a maybe not as organized as a resident as Dr. Singh was. Maybe, it's okay if you don't know what you're going to do yet. If you're still just figuring out PM&R in general, let alone a subspecialty, that's fine. You don't necessarily need to be at the, cutting edge of the research or knowing all these things to be able to match into these fields. I mean, you can still match into a pain fellowship or a sports med or fellowship if you decide that a little later on. Now, pain, you do need to know a little bit earlier compared to all the others, but just to relieve any anxiety that some early M4s or M3s may be having about this.
I wanted to echo Dr. Brombutt's comment. I'm applying to sports fellowship right now, but I didn't choose sports medicine until maybe the middle of my first year of residency. I kept an open mind coming in and then decided that this was probably the best fit for me. Prior to residency though, doing a little bit of sports coverage is it's fun. You get to meet doctors and you'll probably meet some physiatrists along the way. And it's a good way to get your foot into sports medicine.
I think I'm a PGY3, so I'm starting to think about what I want to go into, and I kind of want to follow like interventional musculoskeletal medicine. And initially, I came with the idea of helping people with pain, and then I realized that there was sports coverage, and I was an athlete myself, and I like that sideline coverage that I appreciated. But then, kind of hearing my heart and seeing people in the inpatient setting, which is something that Dr. Russo mentions, it's you get to see all these patients at the beginning of their disability after the injury, and then you realize that they also have pain. And so that kind of made me realize that even though I'm seeing all this neuro rehab, that it's really interesting, all the brain injuries, all the spinal cord injuries, how to help them, how to advocate for them. One of the things that kind of goes unnoticed sometimes with people with disabilities is the pain component. And so, like Sarang was saying, is keep an open mind, because no matter if you're going into something that's MSK heavy or spinal cord injury, neuro rehab, you tend to learn a lot about that specific disability, but also how it entails the whole world of PM&R. And so the best lessons that I've learned as someone that's going into something that's interventional is actually in the inpatient side. So I think it warrants going into any PM&R rotation that you have, not thinking that, oh, it's not the thing that I want to see, it's not the sports coverage that I was hoping for, but every little thing. Pediatric rehabilitation is so interesting. It is very raw PM&R. And so that's the advice that I would say. Just making sure that you keep an open mind and love every section of PM&R, which is great.
I love that. Next question, and we've maybe touched on some of this, but what's kind of your favorite part about PM&R, or or what's kind of the toughest thing or the worst thing maybe about the field?
I think we can probably, most of us will agree. I think the worst thing about PM&R or medicine in general is insurance. I think that's the hardest battle that a lot of us, inpatient or outpatient, or struggle with. But another aspect, in terms of what's the best thing about PM&R, I kind of reached on or touched on earlier, is I think the flexibility of how you can practice PM&R is amazing. As Dr. Russo mentioned earlier, there was an academic provider that ended up switching over to locums. I've heard about countless cases where people are inpatient for half their career and then they become completely outpatient, or vice versa, go into private practice and then go into academia, research, and then go back to, well, usually you do practice and then into research, but sometimes you'll see the other. And so I think that is one of the biggest strengths of PM&R. And to speak on how something that Dr. Ortiz perfectly kind of spoke about is, PM&R, the better you are as a generalist, the better you're going to be as a specialist. And so really trying to learn every aspect of what you can do in PM&R residency will allow you to be a great specialist or a generalist. And I did want to kind of speak on that just for some of the early individuals. PM&R is not a specialty that you have to, like radiology, I've heard, you do radiology and then you have to do a fellowship or a subspecialty after that. That's not how PM&R is. You can do PM&R residency and then practice as a generalist and still end up doing a lot of specialized things in certain places. So.
Yeah, I would say I agree. Yeah, insurance is the worst. It's makes it life hard. Inpatient and outpatient. But the two things. One, again, that getting to see people return to themselves or start to build back function that they've lost is incredible. And then the relationships, both with the patients and then with the families. PM&R is a family sport. It is not just about a life-changing injury, is not just about the person who had the injury, it's about their entire network. And so the relationships you develop are not just with the patient, they really are with the family. They are strong and they have the potential to last a lifetime. So that is definitely the best part. But agree, insurance is the worst. Which is good because it's not the field itself. It's just insurance.
I love this question. I love the points that Dr. Russo and Dr. Brownblatt have made so far. I'll kind of approach it as what I find is the worst part first. Now, I'm early in my training, but one of the worst parts for me is really just the patience required a lot in physiatry. It's sort of unique compared to other medical specialties that sometimes can be solved with a simple quote unquote procedure or a simple sort of medication. Physiatry requires a lot of patience. It requires a lot of buy-in from your patients themselves, their family, allowing their body to heal so that they can develop strength and eventually increase their function and use. But at the same time, while that patience can sometimes make your job difficult and make it feel a little hopeless at times, I think the type of person that is drawn to physiatry is a very optimistic person. And that type of person is really seated throughout the entire field. And that's my favorite part about physiatry, is that I think the culture of physiatry, the types of physiatrists you're going to meet, your co-residents, the PTs, the OTs that you work with, these are all fairly optimistic people. And I think that sort of environment is also unique in healthcare because these are people that are highly motivated. They look on the bright side. They try to highlight the positives. And these are the types of people that make your workday really fun and really positive.
I think as a resident, at least as a PGY2 in the inpatient setting, I think the worst part is, I think it's the sign-outs that we have going into the rehab facility. So we get a lot of the patients coming in from the hospitals after the acute care, and we get their stories, and then sometimes they're not complete. Sometimes surgeons don't give their advice as to what needs to be done after the surgery, and then we have to kind of call them back and stuff. So I think in terms of the logistics of it, I think that's probably one of the worst parts of the PM&R life, is that no one really knows what we do sometimes, and so they just think, oh, it's all rehab. And then but that's also the cool part about it, is that we are the only ones in the room who could prescribe a wheelchair. And I think a lot of our training thoughts is they're common sense. A lot of medicine, it is common sense, but we kind of delve into the data, the numbers, we treat all those things. But in PM&R, we move from the diagnosis into the function issues. And so if we see that someone has a leg discrepancy, we're not going to rush into a surgery. It might be just a heel lift, and that's going to relieve the pain in the back. So kind of going into those common sense components makes it seem like we have solved this with a heel lift, and then people see it as, oh my God, you're a wonderful person, and they're not in pain anymore, and you haven't really done anything. And so it was just teaching them, educating them, giving them the proper equipment, and that's all it is. So it's a give and take, but it's kind of cool that we're like in this little bubble that no one really knows what we do, but once they know, they really appreciate what we do.
Now I would just add as well, one part of PM&R that I find very unique is that we really do get to be advocates for our patients. You know, like a patient with a spinal cord injury, I'm sure you guys have maybe heard the sentiment at this point, but you know, we really are like their primary care doctors. And just one example I can think of on the inpatient side of things, last year we had a spinal cord injury patient, and he had this chronic pain actually that was really like disabling his function in rehab. He wasn't really able to get out of the bed or even participate in therapies. And kind of like Dr. Singh was saying, you know, it takes a lot of patient buy-in, and it can be a little bit frustrating day to day, you know, talking to a patient about doing therapy while they're there in rehab, and, you know, these things are preventing them from participating. But you really have to kind of approach it from the multiple different angles and perspectives. And just this patient, for example, you know, we really got to utilize our rehab knowledge. And he had a spinal cord injury. Could his pain have been from the spinal cord injury? Could it have been, he has spasticity, he had a baclofen pump, could it be spasticity related? You know, it could have been a chronic pain syndrome like CRPS. And so there's so many things from the rehab perspective that we have this excellent knowledge on. And really, we really are great advocates for these patients. And ultimately, we were able to get him to like the outpatient pain medicine setting for kind of the treatment for this chronic pain syndrome. And so we really do have a lot of tools in our toolbox as physiatrists, and it really does feel like a blessing every day to be able to use that.
I think for me, the part that I like the least, and the part that's been most difficult, is sometimes telling these patients with spinal cord injuries and that, you know, they might not be able to walk again. That's been really tough. And you're if you guys do go into PM&R, you're going to have a lot of those like really difficult conversations that are life-changing. Like Dr. Russo said, not only for the patient, but literally the entire family. So I think that is really difficult, but at the same time, it has been really beautiful to also watch them make small gains. And if they weren't able to use their arms to feed themselves, like feeding themselves is a huge win. And I think that is really nice. And I also, like I mentioned earlier, I really like working with the team. And I think most PM&R doctors are pretty positive, which I like that environment as well. So.
Great. Well, thank you all so much. I think that sums up the questions we're going to ask as a big group. I'm going to hand it over now to my amazing committee members, Elise and Jennifer, and they're going to have you guys ask some questions.
Hi, I'm Jen. I'm a fourth year student at UNC, our University of North Carolina. I kind of just wanted to open the floor to anybody in this meeting right now that has any questions for our panelists.
Hi, everyone. My name's Elise. I'm a third year student at Western University, Cop Northwest up in Oregon. You guys are also more than welcome. If you don't want to unmute and say your question out loud, you can put it in the chat and we can read it out loud and leave it to the panel to answer. Okay.
If no one's gonna go, I'm gonna go. My name is Sherman Jones. I am a M2 over at Emory in Atlanta, and a lot of what the participants in this panel, which I thank you for joining, a lot of that has been said is kind of along the idea that PM&R has a lot of outreach with the general population, long-term relationships, and yada yada. So I guess my question, which is probably a very bad question, but I want to ask anyways. What do you think PM&R offers that I guess primary care does not offer? Or what could PM&R learn from primary care?
We haven't talked a lot about the collaboration in our field. So we're an extremely collaborative field. We work with professionals from all different sort of walks. So we have close relationships with physical therapists, occupational therapists, speech therapists, social work. It's a very, 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 very integrated field. And again, I think even more so than primary care, I think we have an even greater sense of how the patient fits in their context, really, and the context of the whole family. I think we really hone in on individual goals of individual patients and then how that fits in their greater context of life. Rather than sort of managing sort of their, chronic medical conditions, we really are helping them return to life in this very, very comprehensive way. So I think it's a matter of how we look at things a bit differently than primary care. I think one of the things I don't know what we can learn from primary care. I got to think about that. I'll let someone else answer and then I'll think about that one.
I think in terms of what's different is the fact that we're not focusing on a lot of these medical chronic conditions. The management of diabetes. I don't know the algorithm of when to start using insulin and injectables. I learned that my intern year and have very quickly now at this point kind of forgotten that. And so it's more so treatment of these chronic medical conditions that we're not, staying at the most up to date on that because we're not managing those things as much. Instead, we're staying up to date on the latest, treatments for autonomic dysreflexia or how to help patients emerge from comas and things like that. So I think that's what's different. Yeah, That's kind of I would say what's different, and in that regard, maybe we could improve upon that and being improving our generalized medical knowledge that family medicine providers would have.
Thank you both for that answer. We're gonna go to Sebastian. You have your hand up. Do you want to unmute and give us your question?
Hello, everyone. My name is Sebastian. I'm a MS1 at UC San Francisco. First, thank you, everyone, for kind of giving us all this valuable information. I had a quick question. I realized someone asked this in the chat. The idea of like sports medicine, I know you can apply via like family medicine, emergency medicine, I think even pediatrics you can apply. I was kind of curious, in your opinion, how the residency of PM&R kind of trained you to be a specific type of sports medicine physician that maybe family medicine or emergency medicine might differ.
I think part of where some of us are struggling with answering these things is almost sounds conceited in some ways, and so I apologize if these answers at all kind of convey that. I think family medicine is a fantastic field, and I don't want to make it seem that I feel like somehow we're better or anything like that. But I will say, in terms of what's different, that I think is very important to highlight, is I think the knowledge that you have of your anatomy and a neuromuscular system in totality is going to be much greater as a PM&R resident than as a family medicine resident. Along those lines, same with emergency medicine, you're going to have a very good understanding. Now, each one of these are going to have their own pros and cons. Emergency medicine, they're probably going to really know how to deal with an unstable spine that's just occurred on the field better than a PM&R resident. But you get some of that already in PM&R residency when you're doing sports coverage. So I think you would cover those basics. I think just in what your education you're going to get in PM&R in terms of your neuroanatomy, your ultrasound skills, your procedural skills, your hand skills, and that I think is going to be up to par with really any of these other specialties in terms of sports medicine or in other fellowships that you may get from PM&R.
There are neurologists who do neurorehabilitation. I put that in air quotes. But their training, even though they have an interest in it or maybe took a fellowship, is very, very different. There's a language that we speak in rehabilitation that has to do with levels of assistance and functional movement and all of that, embracing all these things that are like they don't learn. That's not what their focus is. So I do agree with Dr. Brahmat and everything he said, and then would add in that there's this like a special language that comes along with rehabilitation medicine that is just not a lexicon that other fields really have. And without that, I feel like you're missing something essential about understanding the full function of getting the full picture of the full function of a patient.
As Dr. Russo said, I think, everyone asks, like, what's your, cardiologist, the heart is their organ, right? A dermatologist, skin is your organ. As a PM&R provider, function is your organ. Everything you're looking at is in the lens of how can we make this individual do the function that they're desiring to do better, whether it's training for marathons now again with a weekend warrior, or it's someone who's got quadriplegia and they just want to be able to maybe feed themselves again. You just go looking in these contexts, as all the residents spoke to as well. You're thinking about pain, you're thinking about prosthetics and orthotics, you're thinking about their gait mechanics, you're thinking about all these different things that I think some of these other specialties, you're just they have so many other things they have to know. You need to know the treatment protocol for asthma from top to beginning. Luckily, or maybe unluckily, I don't know that.
Yeah, like one more, just like stroke follow-up in my clinic is not like, do you need to stay on this aspirin and Plavix and continue taking your statin to prevent strokes? Stroke follow-up in my clinic is discussing grief after stroke, working with the family. Like we're talking about returning back to resuming life roles that they've no longer been able to play. It's much more, it's just a totally different focus. And I think that's like essence of PM&R, which is just different than these other fields. Okay.
All right, thank you so much for all those answers. We'll go to Gina next for her question.
Thank you. Hi, my name is Gina. I'm an M2 at Rutgers, New Jersey Medical School. My question is, can you guys elaborate a little bit on insurance companies and how you might circumvent those barriers?
Gina, is it okay if you repeat your question? Because I think you froze a bit.
Oh, yeah, sorry. So my question was, can you guys elaborate on some barriers you face when dealing with insurance companies in PM&R, and like, are there things that you guys do to circumvent those barriers?
On the inpatient side, they are insurance companies and Medicare they're shortening the stays. So they're shaving days off of what they'll pay the hospital or how long they'll allow the patient to stay at the rehab hospital. It makes it harder and harder to like get our job done. Plus they're moving patients out of hospitals quicker, so they tend to be sicker when they come to acute rehabilitation, which means that we're stabilizing and trying to rehabilitate at the same time. Which means that everything that we're used to doing, we have to do at like triple speed. And we just don't have a lot of time, and it always feels too short to families. There's not that there, it's difficult depending like on what kind of insurance, whether you can, if there's anybody to talk to argue for, to do a peer-to-peer for, it does depend on what kind of insurance they have. And there's just inequities to it, no matter how you cut it. That being said, we do what we can, and we work efficiently in teams to try to get it all done as quickly as we can for the patients, and then continue to support them when they move on to the next level of care. Yeah, so that's the inpatient side. Outpatient side, I have less issues with, but that's maybe the supports guys might have a better answer for that one.
And just to kind of further explain what Dr. Russo said in terms of if you don't know, kind of one of the terms she said was a peer-to-peer. So these insurance companies often do have these individuals that have this role, essentially being someone that as a provider you can speak to and kind of advocate for the patient. And so that's a really good way that oftentimes we still can get things covered that they initially denied. The issue in that is, or one of the hurdles, as you asked about, is that these individuals that you're asking and trying to tell them they need something, this patient they've never oftentimes treated that type of patient. So for example, in an inpatient rehabilitation, you'll be speaking to potentially a psychiatrist, not a physiatrist. You may be speaking to an internal medicine doctor. And so they know a lot of things, but they may not know about how a traumatic brain injury course of recovery is. And so it's hard to try to kind of sometimes make them kind of, part of your job is almost educating that individual and then asking them to kind of agree with you. And so that's a delicate balance. But that's one of the things you can do. And it's a team sport, as we've all said. So oftentimes you're using all these other people, your therapists and social workers and all these things to try to help get the patient.
Thank you, guys. We have a couple questions in the chat. I think I'm seeing a theme here of participants asking, what are some things that they can do to prepare for getting into residencies in PM&R? Dr. Jones has answered a couple of things, but I also wanted to open it up to the panel just to kind of see what your guys' experiences were as either an M1 or an M2 or an M3, and what type of things you felt were successful in having a good match.
I will advocate for trying to broadly expose yourself to the field. Like, it is very helpful when we're evaluating candidates and we know that they've had exposure to, outpatient MSK and inpatient brain or spine, just that they have a good sense that the field, how broad the field is. Mainly because the training is, like all residencies, is tough, and that PGY 2-year in particular tends to be heavy on inpatient rotations. And if we're coming in thinking, I'm an outpatient MSK doc, not knowing that you really are going to be, you're really going to be exposed to these other parts of the field, it can be jolting for people. So I think for me, I'm looking for broad exposure to the field and a real understanding of the completeness of the field itself. less worried about if you've done research or this or that into the field itself. It can be difficult, and we know that you have access to what you have access to as far as, you know, your training goes, and not everybody has access to, you know, perfect research to be able to do and put on their resume. When I'm evaluating what people have done, when I'm either for fellowship or residency, or really looking for the depth of the interest rather than sort of a broad smattering of things. I really want to hear passionately you talk about why you're interested in the field, and something you've done that really is meaningful to you. That's really what I'm looking for. And then that you have an overall sense of what we actually do.
All right. We'll move on to the next question that I've seen in the chat. I feel like another theme that Dr. Russo had also touched on a little bit in her last answer was getting involved in research and also finding research opportunities and how people went about doing that.
So when I was applying for a residency, it was about 3 years ago, and so I think the playing field of applications in PM&R has changed a little bit in the past few years with all the signaling processes that we didn't have during application season, and so I think that it may be coming to a point where there are some factors that are going to kind of make you stand out. When I was applying, research wasn't really like an emphasis. And like Dr. Russo said, I think most of the people focus on the quality rather than the quantity of the research or and involvement that you have with the specialty. So for me, it was kind of hard to find a specific research. And I'll be the first one to admit that I wasn't the best applicant when it came to research. The one thing that I wish that I did, however, as a student, was just to kind of have face-to-face with attending. So if you have a home program, I would say get in touch with them, see if they have any interesting case reports. If they have, it doesn't really have to be, randomized controlled trials and like doing IRB approvals. I mean, it's good that if you get access to that, that's amazing. But you could just start with reviewing some case reports, doing some reviews of literature, and having someone that's going to be your advisor when it came to that. So I would say just figure out if there's anything that's kind of relevant to PM&R. It doesn't have to be within PM&R. It could be neurology based, it could be orthopedic based, and kind of put a twist of rehabilitation, and that could help you out. And even an intern year, you can do if you're doing telemedicine or surgery, kind of advocating for PM&R, doing case reports about PM&R in those fields, probably a good idea.
And just quickly kind of trying to, as the theme has been about research, one other thing I would say and has not been mentioned about in terms of making a competitive application, I think, is a ways. It was not a major thing when I went through, but being on the other side of things and having applicants come through that are a ways, that's a great opportunity to be able to make a face to name connection. And so even if you haven't done as much research because there's just not opportunities near where you are, that's a great way to be able to get to a program, show them that you're very interested, that you're all the strengths that you do have, you're able to highlight that in a month-long kind of, hopefully, or at least a few weeks course. So I think that's a great opportunity to try to get your name out there as well.
As an FYI, I agree with the ways completely. As an FYI, there was research released showing that there were more interviews offered to medical students who did specify a geographic preference than those who did not with the signaling. Just FYI, apparently not signaling a geographic location that you're interested in actually resulted in less interviews. Just FYI, that was the data that came in. We had discussed it in our education committee. I just wanted you guys to know that apparently it is helpful to signal a region that you're interested in. That's it.
Great. Well, thank you all so much for your help. I do realize we're coming on the hour of 6 o'clock. People who can stay, please stay. We will have more time to answer questions. People who are unable to stay, that is just okay. We totally understand. Before we do leave, I did want to share an upcoming event with you all that the AAP Medical MSc is putting together about building PM&R student interest groups, M1s, M2s, schools with existing PM&R interest groups that want to strengthen it. Or if you're on this call and you're like, hey, I really love PM&R, I would love to start a PM&R student interest group at my school. The other committees on the AAP MSc are putting this event together, so be sure to stop by if you're able. And I just wanted to say thank you, all the students, for coming and asking such great questions. Thank you for our panelists who spent their night with us. And again, I'm able to stay on and help answer questions, so no one needs to rush off. I just wanted to make sure to share the plug for the event coming up and say thank you to everyone.
Thank you for having us. But one thing I did want to ask if everyone that was a part, I think that question that seemed to be a common theme in terms of comparing PM&R to other fields and other specialties, family medicine, those types of pathways. Please, if you could just put in the chat if what our response was kind of helpful or if it wasn't, to be honest, because obviously a lot of you all are asking that question, and that was not at all something that I thought we were going to be asked. And not to say that that was a bad question, but I just want to make sure we're answering it in a helpful manner. So if you all could let us know, you're still confused, or that helped clear things up, that would be super helpful for me for future references to help other people. So.
Sebastian, if you want to go ahead, you can.
I just kind of want to ask a quick question, a follow-up from Dr. Russo, talking about like signaling. Do you think like and I'm sure like by the time I apply residency, they're going to change the process again. But do you think it would be smart to signal, for instance, in California, knowing that there's only like 4 or 5 programs versus like the East Coast, where there's a lot more? Or like just something that kind of I was thinking about right now.
I think you have to go with what you mean, I think you have to go with what's going to be important to you, because when they ask questions about like what draws you to the region or whatnot, I mean, I think you have to be as honest as you can as far as like, this is the area of the country that I want to be in and the reasons why. There's questions they can't ask you, obviously, but I think what's happening is, I mean, we're just there. Look, it's a work in progress as far as like all of this is new, and we're gathering data. I think they're finding unexpected things as far as how this is all going to work. But it's partly to make it easier on you all too. When everyone's applying to 60 programs, like it's untenable for everybody. So I think just they're trying to find ways to really be more clear about who's really attracted and who's not, and work it out. I think getting down to having the talk with yourself about like what it is that's really important to you, what you're really looking for in a program, and what balance you're going to need in your residency life, whether that's being close to your a support system or whatever. That's really going to be more effective for you ultimately.
Thank you.
Is there anyone who put a question in the chat that you feel we didn't adequately answer? We are kind of at the top of the hour, so just any last minute burning questions.
I would say for Dr. Jones, in relation, if you're still on to your thing, the stuff that we learn in PM&R, you don't learn anywhere else in medical school. So like management of spinal cord injury, management of brain injury, they're oh, I'm sorry, I'm so neuro. they're not covered elsewhere. In disability education, there's so much wheelchair management, bracing, all of it is just even again, as Dr. Brahman had said, the neuromuscular exam, it's covered in so much more detail in our residency than in any other field of medicine. So like my husband is cardiology, so he went through internal medicine, cardiology. I mean, what I know and what he knows are two different worlds. You know, he's learned through me that we're great and that everyone needs rehab, but none of what I know and I learned in residency is anything that he was taught. So like we really are a separate specialized field that has its own world. I hope that's a little bit more helpful. We really are not internal medicine doctors. We're not doing it, as Dr. Brahman said, hypertension and diabetes and chronic illnesses. We are dealing with spinal cord injuries and brain injuries, and we are the only people who really know those fields. So I hope that's a little bit more helpful.
And Dr. Jones, I think one other thing that may be helpful for you in determining the differences is maybe look at residency websites and look at what their rotation schedule is like. That may be helpful as well in giving you insight into, okay, you're going to do pediatrics rotation. You're going to learn a lot about cerebral palsy and different orthotics that are used or different products that can be used for that. You're going to do rotation at a skilled nursing facility and taking care of individuals there. You by looking at the schedule, that may give you a lot of insight into how it's different from a family medicine residency. You're probably not going to do OB-GYN, but I think even in family medicine, they're not doing OB-GYN much anymore. So, it just depends, but hopefully that'll help you as well, I think.
I think one of the things that kind of got me confused as a student was people tell you like cardiology, they treat the heart, nephrology, they treat the kidney, and then we treat the function. And then function is such a broad term sometimes that we don't really think about it. And it's the language that Dr. Russo said, like we have like levels of assistance. We have all these equipment tools that we can provide to the patient. And while we still have to know about what hypertension is, what urinary retention does, all of these things and antibiotics and all of these things, I think it goes back to how is the medical issue going to prevent them from doing the daily life activities. So if they have hypertension or if they have orthostasis, low blood pressure, are they going to tolerate going to doing their dishes? And so how are we going to modify their function so that they don't have to kind of have these orthostatic events? And so while we still have to know these medical issues, the function is that it's essentially how do we make sure that all the medical components that they have is not interfering with their lives. So if they still want to work, we have to modify their world. And that's what PM&R really focuses on. How do we make sure that the environment matches to what their level of functioning is at that time? And so I think that's what PM&R really hones it in. All these medical stuff we have to know, but how is that going to affect the function is the key answer that we are able to provide.
My computer is about to die, so I'm gonna sign off. I'm sorry, guys. But thank you for your wonderful questions. And I always say that the medical students knock my socks off almost every time I interact with them. So keep at it, guys. Okay. Bye.
We have it talking about all the medicine that you general strokes need to know. We have a question that says, I was curious about the benefits or downsides to a categorical versus advanced residency program. And if you did an advanced program, what did you do during PGY1?
I don't think there's any necessary advantage or disadvantage. I mean, the basic crux of this, typically, a categorical and advanced, the difference is the location of which you're training. That's the primary thing you're going to be experiencing. So in a categorical program, you're going to be doing your intern year, your PGY1 year at the site of your eventual advanced program, PGY2, 3, and 4. So location-wise, it's a single move, it's a single facility, it's a single EMR system, it's a single type of faculty and culture and network that you're working with. That obviously has a lot of positives because it's really only one set of change that you have to get used to. But at the same time, I was in a very specific situation where I matched at a residency that I wanted to go to, but I'm not from that area. So I actually chose to do my intern year back home so I could spend some time with my family and spend some time with my loved ones during an important time in my life. So that's a choice you kind of make. And I feel like location is really kind of the crux of that. Having said that, I do think the type of training you do as a PGY1 is an important decision to make, primarily because when you are a physiatry resident, you can't stop being a doctor. So as a PGY1, I did an internal medicine residency after speaking with a lot of residents in PM&R that really reinforced that you need to be able to at least be comfortable and confident in addressing medical concerns with your patients and their families, handling things on call independently in a swift manner. And that requires a good amount of training in medicine or a surgical field. So I do think, taking your PGY1 seriously and doing something like internal medicine or surgery, if that tickles your fancy. I didn't want to be in the OR that long. But medicine, I really think it's a big advantage because it's going to make the remainder of your career in PM&R so much easier. You're not going to have to worry about doing some of the basics, and you can just focus on learning that language that we've alluded to so much tonight.
All right. Well, thank you, Dr. Singh, for that answer. And I just want to round out tonight. Thank you so much to all of the amazing medical students who joined us. We're hoping that you learn more about the amazing field of PM&R. And thank you to the amazing residents and attendings who were able to join us. So please reach out to the AAP MSc if anything else comes up. We would love to be a resource for you. We put out podcasts, we do events, there's conferences, lots and lots of different ways to get involved. We talked about representation and rehab. There's, PM&R scholars, pathways in PM&R. There's lots of groups for you all to get involved in. So we encourage you to do so and hope this is beneficial. But thank you guys so much for coming. Yeah. Have a good night.
Thank you.